Well, good afternoon. Welcome. It's great to see so many folks assembled here in our auditorium. Well, of course, we have others online. And welcome to our College of Medicine's Dean's Distinguished Lecture. And we're absolutely thrilled to have Dr. Marcella Nunez-Smith here with us today to share her presentation, 20 Years as a Health Equity Researcher, My View from Research, Government, and Nonprofits. So, Dr. Nunez-Smith, thank you for being with us here today. I know we took advantage of your time. You've been here almost a couple days and talking to us about your work. And again, thank you to everyone who's joining us. We launched these Dean's Distinguished Lectures in the fall of 2022 to highlight research topics that integrate efforts by multidisciplinary teams. As we all know, biomedical research really is a team sport spanning a variety of disciplines, and the things that are going to make the most impact in the lives of our patients in the scientific realm are really things that do combine the expertise of multiple disciplines. The critical objective of this lecture series is to engage our College of Medicine community with leading edge science and medicine that involves both the depth and breadth of scientific knowledge and technical expertise. These lectures are leading to further insights into building successful teams within our College of Medicine, as well as new ideas about diversifying and expanding our research programs at all levels and all disciplines. So we're pleased to have hosted amazing scientists, including Dr. Nunez-Smith, who are leaders in important contemporary scientific endeavors and who make seminal contributions in their field. With that, I get to introduce Dr. Karnik, who's going to do a more formal introduction of Dr. Nunez-Smith. Dr. Karnik, of course, is the Usha J. Raj Professor of Psychiatry and Pediatrics. He holds many titles in addition to that. He's director of the Institute for Juvenile Research, co-director of the Center for Clinical and Translational Science, and our interim director of AI Health for All, a Center for Health Equity using machine learning and artificial intelligence. So Dr. Karnik was kind enough and generous enough to sponsor our invitation to Dr. Nunez-Smith. That's perhaps why she said yes, given her very, very busy schedule, to join us on campus for this lecture. So Niranjan.
So I'm actually not going to do a formal introduction. I'm going to dispense with it because if I do the formal introduction, Dr. Nunez-Smith won't get a chance to speak because it's too long. But I will tell you how I met Dr. Nunez-Smith. So I was appointed to the Health Disparities and Equity Promotion Study section, and she was serving on that study section already. And that study section was a remarkable group of people. It was very much this amazing group of scholars who have really transformed the field of equity research. And so for me, it was a very intimidating moment to be in that first meeting with that study section. And I remember listening to the folks giving their commentary and their reviews and thinking, now that person seems like the smartest one here. And it turns out she is, and she was. And she has been, I think, a transformative figure in the field and has really changed Yale University for the better and brought them into a new era around doing equity research. And for us here at the University of Illinois, she is very much a kindred spirit in terms of the work we do and our mission. I will only state two things from her bio. One is that she is the C.N.H. Long Professor of Medicine, Public Health, and Management. She has this amazing ability to transcend the various schools at Yale, including their business school. And she served as the senior advisor to the White House COVID-19 response and chair of the presidential COVID-19 Health Equity Task Force, and was also co-chair of the Biden-Harris Transition COVID-19 Advisory Board. Those roles were seminal for her work, and I hope she's going to share some of that with us. So please join me in welcoming my friend Marcella.
Thank you so much, Dr. Karnik, Dean Rosenblatt. It's such a great pleasure to be here. Thank you all for coming today. I've really enjoying my time here at UIC. I want to just take a moment to acknowledge all of the really impressive, amazing work that is here. The leaders, the learners, all impressive. And I was saying, back to that kindred spirit, there's no place I'd rather be than at an institution that is so deeply committed to mission and grounded in all the work you do and caring for patients and community. So my time together with you today, I'm keeping an eye too, because I want to make sure we do have some time for discussion and question. And I know we have, for those here on this campus, an opportunity to after the formal talk. But um, uh, invite you to sort of take this memory stroll with me, right? I was looking back and saying, this is 20 years for me as a health equity researcher and 20 years on faculty at Yale University. And as I think about what will hopefully be the next 20, it's important to pause and reflect and think about some of the lessons learned and opportunities. And I've been really privileged, deep honor to sit at various tables, research, government, policy, and nonprofits, to name some. So we don't in this deck and in this talk, I don't get to go super deep on any of them, right? Where it's a survey class, as it were, in some of these experiences and some of the work that I've been very, very fortunate to be a part of and help establish throughout. My one of my not so secret intentions for being here and being in community with all of you is because I see great potential in this moment for collaboration, right? And for bidirectional learning and exchange. So really hoping that as we go through this conversation, that for each one of you who's joining us in this talk, there is something that resonates or you find interesting that might lead to further discussion and conversation. So we tried our best in one place and one slide to sort of summarize some of the experiences that have been really meaningful to me. And I'll take a deeper look, but I sort of often will start talks like with the ending, right? Because I have another not so secret agenda, which is to hopefully have everyone in this room by the end of our time together be thinking of all the ways in which you're contributing to, right? Naming those, thinking about them, thinking about where those opportunities are to lean in even more in this moment. And really, in that last pillar, I spend a lot of my time now thinking about my role as a member of community. And whether that community is my Yale community, New Haven, larger national community, but I have found both much meaning, purpose, and fulfillment in service and in volunteerism, and we'll end up sharing some of that with you as well. So here are some of the lessons, like I said, starting with the end, right? Like, what are some of these lessons that I reflect upon at this particular juncture? And this is not by any means an exhaustive list. I mean, research, policy, service, these are very humbling activities, right? So there are many lessons to be learned and to take away. So this is, but really these are ones that I find I continue to come back to and feel really compelled to share with others. So I work at this very hard, right? Number one, thinking about how to be a good partner in the scholarly endeavor, right? And there are those who will do community-based participatory research. There are those that are doing community-engaged research. There are those who are trying to identify what and if and who might be good community partners in their work. And I really encourage everyone to sit with that and to think about, how can I partner with someone or someone's who can make my science better? Really early, I was fortunate enough as a clinical scholar at Yale to be taught CBPR, to formally go through that curriculum. And I always return to this as a very basic and foundational principle for me and all the work that we do through my research centers and programs. I do want to leave folks with the knowledge that partnered scholarship is not a nicety, right? I often run into folks who are like, well, that's a nice thing to do if we can have the time, or if we can, we do it in the hopes of feeling perhaps warm and fuzzy, but the science is better. So there's one of the groups I get to work with is a steering committee and community engaged projects, and they're later in the deck. But we were working on a large center grant together, and we huddled in this conference room for weeks, right, working on this grant. And I'm not embarrassed to say that the parts of the grant that scored the best were the parts written by our community members, right? Those were all the ones and the twos. And all of our academic science work did not score ones and twos, right? And it was, I think, a really important lesson for us, right? Not that we were in some way sacrificing, right, to make space for others with different expertise at the table, but precisely because others with differing expertise from ours were at the table, that made the work actually better. I had a chance earlier today to sit with some of your amazing learners here in this community. We ended up talking extensively about mentoring. I think few people would be able to reflect on their careers without reflecting on the mentors and sponsors and advisors who have helped them along the way. I know many of you are paying it forward and doing that work now. I have many surprise stories of finding mentors in unexpected places. So encourage you to be open in that. I've also found mentors in interesting places, right? So try to watch out for those mentors along the way too, right? Yes, appreciate that. So so number 3, and I feel like this is really important, and I probably didn't get to talk to the learners as much about this as possible because I get invited to deliver this distinguished lectureship. And I'm grateful for that. But often in these bios and in these things, it makes it seem as though, it's like a Midas phenomenon that everything these people do and so successful. I don't know if any of you have done this, but as a team on a regular basis, we do our failure CVs. And we sit there and we write about all the things that we tried to get and didn't get, denied. This grant was one, right? The failure CV. Mine is about 2.5 times the length, right, of my actual CV. And I want us to be able to talk about this as a group, right? This need for us not to avoid failure, right? Right. Lots of wise things have been said about this. If you're not failing, you're not trying, right? And so it's part of the process. We have to be able to talk about this. I think the real risk is when we just fail slowly, right? We're taking too much time, too much energy, too many resources. So fail quickly, try to fail fast. My team is invaluable. I pour into the team always. That's my top priority. So I encourage everybody here to think of yourself as a member on the team, as a leader on your teams. Remember to say thank you, right? Every once in a while. Remember to take care of folks. Ask how people are doing. This is a marathon, right? The work we do, all research, and certainly health equity research. And then the value of service now more than ever. So I linger in that longer. I will talk faster through many of these slides, right? I will return to this. But I think it is important for you to have your list of 5 or 6 or 10 lessons that you can return to, right? Because sometimes in the work we do, there are valleys. And I find that it is very helpful in those moments to turn back to that list for inspiration and motivation in the work. I don't intend for this to be, a lecture on health equity. And thankfully, I think this is a field I was reflecting that when I was a medical student, the term didn't exist, right? And we can all tell that I'm very youthful appearing, so clearly, right? This is recent current history. And the fact that we have a field now that's established and for certain, always to stop and pause and honor the many scientists who have come before, right? By whatever name the field was called, many of these folks were disbelieved as they spoke about the existence of health and healthcare disparities. Many people's careers were marginalized. They were not invited to dean's lectureships, right, on this work. So it is important to understand the root too of this field and to stand on those and acknowledge the work that has come before. So these are just a couple of the models and the frameworks. I always talk about health equity as an opportunity agenda. That is what we are doing. I'm very grateful to have seen a recent expansion in my career of disparity populations at the NIH, right? So that's a list that has really grown as we've come to understand the many populations that are affected by health disparities in our country. And as we've come to understand that those outcomes, only 10 to 20% of the variance is due to the quality of clinical care. Now, that is 10 to 20% too much. I'm not here as a defender. We have to study, as many I know of you do, those variations in care and en route when those are unacceptable. But to think about really this pie that I see in my head visually, those social structural drivers, the environment, right, where we live, where we sleep, work, play, and pray, as having such large influence on our health. So this is the NAM framework as well. So this is part of the great team that I work with. These are the faculty at the Equity Research and Innovation Center, or ERIC, as we affectionately call the center. ERIC is now celebrating 11 years, and ERIC came into being the same summer I had my twins, and so I say I had triplets that summer. And ERIC, I can always track then, is 11 years old. This is a really I'm lucky to work with all of these folks. The font is small, but people are from every department, right, across the health professional schools and others, and everyone here is leading their own program of science and scholarship at ERIC. This is a bit of a snapshot in our work over the past, the past year or so. We lead with our learners. We're really excited to have postgraduate associates as well as undergrads and high school students with us sort of all the time. We are, and all the programs there, extramurally funded. In this past year, 40 active grants, a lot from NIH, but other funders there as well, and the publications. But over on the right, I think is more about like, well, what do we do? And we work to advance the science of partner scholarship. Should not be a surprise, given the #1 lesson learned that I shared. But it's really important to underscore that we're thinking about the science of partnered scholarship, which is important. Coordinating multi-site initiatives and being responsive. I mean, this is a great superpower to have if you can, right? Agility and dynamism, and always to have space for what might be around the corner that we haven't seen. And that certainly happened with us for, COVID, for example. So I'm going to walk through just a couple of our projects really briefly. I did want to acknowledge some of the community partners that I've privileged to work with at Yale, both the steering committee and community partnered research on the left, the cultural ambassadors on the right. The steering committee includes leaders of community-based organizations, EDs, chairs, representatives from our local government. The deputy mayor is there, the head of our public health department in New Haven. Really people who are there because of role, right? The sphere of influence that they have been coming to this table, right, for 20 years. We always say that we sort of follow some of the rules of relationships. Like, we've agreed to disagree. And how we keep track of the health of this group and our partnership with the ambassadors is because we're not looking for assent in these spaces, right? We are actively seeking dissent. The reason to come together to work on science and scholarship is to make sure we are considering all the things that we can foresee, right? And plan around and mitigate that. So the second we find everybody sort of nodding and checking, then we know that we need to refresh. But this is a group that doesn't fail to voice, right? And bring to us those checks, as does the Cultural Ambassadors Program, which is a statewide partnership with AME Zion faith leaders, as well as Junta for Progressive Action, a Latino serving community-based organization, focused a lot on clinical research and clinical trial participation. Excuse me. So we are really excited. We are literally weeks into this new opportunity. This is the COMPASS program out of the NIH Office of the Director, which is about putting community expertise at the fore and funding community-based organizations to lead structural interventions that will promote health equity. We are one of 5 new health equity research hubs that have been brought in to work with those what are called CHESI sites in this work. And we're really very much looking forward to those partnerships with those sites and bringing all those lessons we've learned from over 2 decades of working in New Haven and Greater New Haven. These are the leaders for the COMPASS team. For each one of the hub units, we mirror ourselves with a community-based community researcher and an academic researcher. And on our multidisciplinary expert panel, we're leaving those 5 seats for each one of our CHESI partners to be able to nominate someone to serve with us at the level of the hub and that expert panel. So we're really excited about that. Some of the work I wanted to share that we're doing locally, all of those projects are national, they're in different locations across the nation. But we're trying different Yale signature initiatives, and back to that spirit of we're going to try to fail or flourish fast, right? But we're going to take some risk. So this is the Community Health Equity Accelerator. Essentially, we have impaneled a governing board. Mr. Smith and Mrs. Spell are our co-chairs. The group is about 15 in total for that governing board. They have a full budget, right? They set, we're going through 3 cycles. Each cycle, they set the sort of area of focus. The first one was pediatric asthma. We're now in a hypertension cycle. And then they draft RFAs for community organizations and researchers to work together on proposals to come in for an 18-month rapid implementation of existing multi-level evidence-based interventions in our community. We're really excited about this, right? And we are definitely thinking of this through an implementation science lens and thinking about the lessons that we learn. We are in thought partnership with our Community Foundation for Greater New Haven and our health system. But of course, everything is just a little sprinkle. I could talk for the whole time about CHIA and how excited we are about that work. Another initiative that we're sort of still in pilot, emerging from pilot state now, is our Community Research Fellowship Program. And I know that there is a lot of attention here in this campus too for integrating and engaging community perspective and expertise in the work. In this program, we partner with CARE, which is a community-based organization. They identify the fellows. The fellows are competitively selected. They're trained. We also trained host labs or teams at Yale. We've done our pilot at the Cancer Center. We then embed the CRFs, usually as a dyad for 9 months, in the team, right? So the CRFs are part of the team. The team changes their time schedule. These folks are all working full-time somewhere else, able to devote about 5 to 10 hours a week to this project. We're really excited about this. The feedback has been incredible from both our fellows and our PIs. We're expanding to other cities. We've had, I don't know if it's on there, I think that number is higher now. We've had about 60 fellows who've come through the work. Some are hired onto team, but that's not the goal necessarily. What we are really excited to see is our alumni who join our community advisory board and in other ways help. So another initiative we're really excited about. So I'll just turn quickly to some of the work that we do in terms of multi-site initiatives. This is PREDICT, a body of work where we think about quality of care measurement, particularly the patient-reported experiences measures and the experiences of care. I was lucky to be at Yale when we first competed for the CTSA award. At Yale, our CTSA is housed in the Yale Center for Clinical Investigation, or YCCI. So my YCCI Scholar project was thinking about these questions of the experience of patients seeking healthcare and thinking about healthcare discrimination and a taxonomy. I was able to then use that preliminary data to compete successfully for NCI funding, to continue the development of that tool. And we're currently working with some part of that work funded by Genentech, thinking about our quality of care metrics at our cancer hospital and cancer care system. So to turn now to another project that is housed at ERIC, which is the Eastern Caribbean Health Outcomes Research Network, or ECORN. I like acronyms. You're going to see a lot of acronyms. I do like me an acronym. And up left is a convening of the UN, right? That's familiar to everyone, and that is in 2011, right? And they convened, it was a high-level meeting on a health issue, specifically non-communicable disease. And it was only the second time in the UN history that they had convened solely around a health issue. People will know, I mean, prior to that in 2001, it was around HIV and AIDS. And this meeting was called by Sir Trevor and Sir George, who were representing CARICOM of the Caribbean community, to say, we are besieged by chronic disease in this region, and we really need solutions, right? And what happened at this convening and this convention was learning and understanding that there really just weren't even basic data infrastructure in place to think about the burden of chronic disease. Around that same time, I was working with colleagues to publish and look at healthcare in the U.S. territories. I'm from St. Thomas, U.S. Virgin Islands, one of the 5 U.S. territories. And we were maybe not surprised, but still shocked by what we saw in terms of differences in the quality of care. As we thought about what to do next from this paper, we were focusing on quality of care, but in talking to partners in region, that same issue came up at the UN, where there was a need for basic surveillance data regarding chronic disease, and particularly in the context of emergency preparedness and thinking about how to get ready for hurricanes. And so we established ECORN in that setting with funding from NIH initially, and the other funding is on the bottom. At the core of ECORN is now an intergenerational cohort of community dwelling adults and children. We are beginning wave 3 of data collection. And there've been a number of ancillary projects that have grown out of this work that we're really excited and proud of. The coordinating center is at Yale, and our partners are at the U.S. Virgin Islands and Puerto Rico, and then Trinidad, Tobago, and Barbados for contextual comparison to the 2 U.S. territories that are located in the Caribbean. A hallmark of our work at ERIC is thinking again about how do we partner with the right constituencies to guide our work in meaningful and important ways. And so ECORN is certainly no exception to that. And this is the ECORN Governing Board, and pictured are the PIs of it, as well as Sir Trevor and Dr. Raxter, who are chairing our governing board for us, and really pushing us to think now about climate and health in the region, of course, as well as aging research. I also wanted to share with you one of our more recent projects. ECORN is now in its 10th year. But this is Equitable Breakthroughs in Medicine Development. And this is a pharma-funded project. We're working in the geographic South, thinking with community-faced and placed clinical sites on how to increase their capacity to conduct clinical trial research. So both thinking about technical, operational, regulatory support, as well as working with their community partners and community leaders around co-governance. And we're really excited because one of the EQBMed innovations just in press this week is our maturity model, right? How do we think about working with each of those sites to assess where they are, right, on this journey towards being able to recruit and retain patients for clinical trials? And in this process, the sites lead, right? They set those goals. It is our job as EQBMed then to help match them with one of our several dozen infrastructure partners to help them grow and achieve and reach that capacity. It might be a bit hard to see. We have 9 of the 10 initial sites identified so far. Not all have been formally released, but that is where we are working with amazing partners now. And in this space too, as in all others, we think a lot about our governance structures and putting in ways to hold ourselves accountable to the communities that we intend to be of benefit to. So the executive committee for EQBMed is pictured there, and then we have over 50 members of our advisory committee representing a number of community-based organizations, advocacy organizations, professional associations, and others. And then maybe to turn for just a few minutes to that last hexagon, as it were, around emergent and responding to emergent needs and emergent research priorities. So very early on, this was maybe April 2020, my colleague, Dr. Carrie Gross, who's also in Journal of Internal Medicine at Yale, reached out. Right. And he said, I think there's really an opportunity for us to try to do some work thinking through our statistics and our data when it comes to mortality and mortality differences for COVID-19. And there were maybe 2 top findings, right? One was that we recognized, right, given the reality that certainly when we think about populations of color, right, sort of live sicker and die younger in this country, that we were not age adjusting, and that really was in some way, in all ways, underestimating the mortality rates for COVID. We also found, maybe what surprised us even more on the right, was just the data deserts when we were trying to just get these basic demographic information about COVID-19. And everywhere that is gray, essentially, we were able to find no data. And there were only 8 states that met our threshold for high quality data at that time. So I would hold that because we're going to come back to that. I'm really quite proud because the leadership team at ERIC really stepped up in this moment. And we were able to launch several research pods that invited in collaborators from across Yale University, bringing in over 50 researchers, I mean, people who previously had no affiliation with ERIC whatsoever, to lead on myriad projects related to the pandemic. Some that were speaking right to policy, as in that top left, thinking about how to provide supportive quarantine and isolation services to people in the state of Connecticut who might need them, to thinking on a national scale, partnering with others on some of the first and largest surveys around attitudes and behaviors and experiences, to thinking about work that we were doing right in our own health system when it came to things like triaging and resource prioritization and other scores that were being used for determining allocation of resources. And this is something we're doing now that also very much is in the policy space. And so we just launched this as well. I'm chairing a statewide maternal health equity advisory committee where we are asked to deliver recommendations next year, focusing very much on severe maternal morbidity in our state, and thinking about recommendations and solutions for that. So there are many, many pictures in this deck, right? Which is very intentional because it's a reminder to us that we do this work in teams, right? As the dean said. And I am always very grateful for the teams, and sometimes it is the role to lead and sometimes it's the role to follow. We will all switch those out. But I'm incredibly grateful to work with these many amazing colleagues. So I'm going to shift a little bit to talk about maybe policy more directly and my experience serving during the height of COVID-19, both at the state level as well as federally. So very early on, our Governor Lamont set up an advisory group to help the state government think about the response to COVID-19. I really give a lot of credit to the Lamont administration. This was one of a few state advisory committees that had a specific call-out committee and focus on those groups that were most at risk, right? Those populations that were being disproportionately impacted and affected. And so at the time, I was served on the main advisory group as well as chairing that committee. This was incredibly formative. The group, the community committee brought together, not usual suspects and many people who were directly affected. So including our relevant commissioners, senior leaders within the administration, also people who are working and representing those very much on the front line. It was a bipartisan group of members as well. Only for time, I won't go into the details of the work, but we I think as a committee both took our charge very seriously and welcomed, in fact, having that opportunity to be part of the decision making for the state and the state response. So fast forward just a few months, maybe this is now in the fall of 2020, August or so, and I got a phone call one afternoon. Now, this is when I pause because I most often say to people, protect your time and try to say no to things. Self-care, wellness, right? All of that, it's incredibly important. And sometimes you have to get to yes. Okay. Both things are true. And I got a call one afternoon in August of 2020 from a dear colleague of mine, Dr. Howie Foreman. And he said, the campaign is going to call in 2 minutes, please pick up. And I was in the middle of doing a town hall for parents, right, for the governor, yes, on their concerns about school, right? And it was by Zoom, of course. So it was a little awkward because, but I had to sort of pause, right? And I didn't really understand what any of those words actually meant. And when the phone rang again and I answered, the person said, "Hi, I'm Jake Sullivan. I'm calling from the campaign. Can you brief the candidate tomorrow on COVID-19 health disparities?" And we can have side conversations about that. I really didn't know any of those words, right? I didn't know exactly what a brief was. I didn't know exactly what that meant, but my stellar team stayed up all night with me, right, to prepare a briefing memo. And when we briefed, it was the day after the candidate Biden had announced his VP pick. So the VP candidate as well joined for that briefing, along with Doctors David Kessler, Dr. Murthy, Dr. Nikki Lurie was also there at that briefing and conversation, where we talked almost exclusively about COVID-19 health disparities. I went on to, with Doctors Murthy, who would be our Surgeon General, Dr. Kessler, lead the transition team, and that's the group that's focused there. One of the things that that we did as that transition team was lead and contribute on that national strategy for COVID-19. There wasn't one existing at the time, and working with a lot of the policy transition teams on getting this executed. And leading on goal 6, which is to protect those most at risk and advance equity, including across racial, ethnic, and rural urban lines. But equity was very much infused. It was very much a mandate from the candidates that everything we think about in the response, we put equity at the center. So this is a point where not everyone knows this information that is on this slide, but certainly from before day one, this was a target, right? There was Operation Warp Speed that was making considerable and great progress, right? We have to start thinking about vaccinating an entire nation, and what does that look like? And what it looks like is hyper-local efforts, right? I'm looking around the room at folks who are leading, designing, vaccinating, doing that outreach. Everyone here, right? So there's that team sport effort. And together we did this as a country, right? We got to vaccination parity for adults for COVID-19 in September 2021. And I think it's really important, right? Obviously for the pandemic, but I think it's really essential because so often when we talk about health equity, the boulder can seem extraordinary in size and the hill can seem so steep. And folks say we don't know what to do, right? We're not sure where to begin. But I would say we do know, and we can do it, and we can achieve it. And this was a moment where we set a clear target and we met that, right? And so you should pat yourself on the back because that is a we lift. UIC certainly at the forefront. So this is the how, right? I think not for us to walk through it all, but these are the principles, right? These are the cores. When you decide that we're going to row in the same direction towards an equity goal, there are these basic fundamental things that we have to pay attention to, right? We have to prioritize access, right? Which we did for vaccination distribution. We set up, the president set up several dedicated vaccination channels, making sure that we were using our data. We used SVI to guide, right, a lot of that access work. You have to address structural barriers. Every week, I hosted 6 to 9 stakeholder or constituent roundtable, intimate off the press conversations with people. The beginnings of those were always, we didn't ask you to join us to be told we're doing a good job. We want to hear what is not working, what's not going well, so we can try to intervene. And so working across sectors here, especially, this is private sector stepped up incredibly to think about transportation needs, childcare needs, and others, right? And then, of course, we talk so often about trust. which here showed up as vaccination confidence and thinking through how we can work with messengers who are trustworthy and making sure that we are staying in touch with those trusted messengers so that their messaging was accurate, correct, and well-informed. So earlier I talked about the paper that Dr. Gross and I and others published very early on where we had a map that just didn't have data, right? And this is where we were by 2021 and the right, where data quality had much improved and data reporting much improved. And we can certainly talk about why this did not happen by default or by accident, but I think it's really important. And I come back to time and time again the importance of data, and it carried through for the work with the Health Equity Task Force. So on day one of the Biden-Harris administration, signed an executive order, the president did, that brought the task force into being. This task force actually followed a blueprint that then Senator Harris had introduced in the Senate for a COVID-19 disparities task force to look at these issues. And I was very excited to be asked to helm that and to work with these incredible members. And similar to the work at the state, taking a lot of those lessons learned and understanding from what we did in the state of Connecticut, the people, the representation that was necessary to make it effective, thinking about those who were experts and champions and representing those groups that are being the most affected. And also on the bottom, those who are in senior leadership positions where those levers of power could be pulled in order to make change. We worked rapidly, right? So it kind of hurts a little bit sometimes to say like, we have half a slide, right, dedicated to the incredible amount of work that that this group put in. I mean, literally thousands of hours, meeting with dozens, hundreds of subject matter experts to generate these recommendations, which were delivered early in October 2021 to the president, along with an implementation roadmap and an accountability framework. So these 5 in the circle are sort of top lines, but the recommendations, there are 55 recommendations that are available in the task force. Really importantly, the audience was not limited in any way to the federal government or even to local government. It was really intended as a resource to anyone in any sector thinking about and considering health equity and committing to it. And these are some important themes, right? Thinking about the need to invest in community-led solutions to address health equity. And the invest is important because so often we will invite community partners and others, to a table that's been preset, where we already maybe have a sense of our questions, where we and academics are controlling the resources. And so it is really important to acknowledge that and create opportunities such as Compass, where organizations can lead and bring in the academic expertise that they need. Just unparalleled need for us to enforce a data ecosystem to promote equity-driven decision-making, to increase accountability for health equity outcomes, to think about our workforce, right? So obviously put yourself in October 2021 and the need for us to pay closer attention to our workforce, both our public health workforce, our community-based workforce, and others. And then a structural note, right? For anyone and any entity working on health equity, that it has to be everyone's responsibility, and yet there must be a center nidus, right, for that activity, for coordination, control, and accountability. Okay, so I'm going to take a few minutes just to talk about nonprofits so that we have time for any questions or comments or conversations. So I started up top saying that I have really found deep meaning and purpose in volunteer service at a number of boards. And I'm becoming an amateur student, I think, of that sector, right? Particularly philanthropy and particularly now. So this is just a snapshot of some of the changing realities, right? The number of 501c3s that are growing, the ones that are exclusively dedicated to health might potentially be on a decline if you look at national trends, but we'll see. So I'm going to share quickly from just a few of the boards that I'm on, some of the work. The Community Foundation for Greater New Haven is one of the largest community foundations in the US, one of the oldest as well, coming up on our 100th next year. I serve there on the board, and I'm currently board chair. We just welcomed our new CEO, Karen Du Bois Walton. The beginning of November 4th was her first day, and Will Ginsburg retired after 24 years of service. But really instrumentally, right, thinking about the $800 million in assets under management to support a 20-town region and what we were called upon to do and lead on in COVID-19, and really courageously, with Will on the board, going into our nest, right, to pull out resources to be able to meet the need in our community. And then thinking long-term through stepping forward about an opportunity agenda for those who lived in our 20-town region. And I also wanted to highlight the Great Give, which is, we're not the only community foundation that does this, but this is a wonderful way that we help support many of the nonprofit organizations in our catchment, creating a platform for giving, right? That is always active, but particularly we make a campaign around these early days in May. And beginning in COVID and sustained since, we have seen over $3.5 million raised through that Great Give every year. These are the amazing people I get to work with on the board of the Community Foundation. I mean, we are here in Chicago too. I would be remiss to not point to the many other foundations that are out there as well, doing really important stepping forward type work in response to COVID and others. I'm on the board for KFF, formerly Kaiser Family Foundation, now rebranded to KFF. You may have noted, but as we went through the slides, a number of our data sources that were valuable to us responding to the pandemic were from KFF and other organizations like that are outside of government, but really do incredible policy work and polling work, and also with KFF News doing incredibly important journalistic work now as well. And Drew Altman is the president and CEO. This is the board of trustees for that group as well. Amazing individuals, all similarly thinking about how to continue to secure the important role that KFF plays in our policy discussions. And then this is a local nonprofit that is in our state. It's statewide, Connecticut Voices. It's a think and do policy tank. And so one of our important contributions is being able to provide for our legislators every year, sort of our briefing book and policy that is very rigorously analyzed, proposed, and discussed by the members of the CT Voices team. And Emily Byrne is our executive director. And here is our amazing board of directors at Voices as well. And then just to end, because so much of what I've talked about has been, some of policy, funding, grantees and others. I'm thinking a lot about meeting social and basic needs. But I recently joined the Marfan Foundation board as well, right? There are foundations out there that are funding research and researchers. I think this is important. My family is touched by Marfan syndrome. I'm a rare disease parent. And I think it's really important for us to understand perhaps the universe of nonprofits and other entities where we might be able to contribute and bring our service. So as I come to a close, right, we're getting towards that, my ask of you, right, my charge, which really is thinking through, just like at the top, right, your lessons learned, but also where your contributions are and can be enhanced. I often, reflect on, yes, the important role of nonprofits, but much of the work I think is done in maybe shadow. Like not everyone is aware of all the work that's being done, even in your own community, by nonprofit organizations. And there are lots of ways to get involved. Most certainly donating is a critical way, but board service, I really encourage people to consider that. I have learned so much. This has become a professional development opportunity for me that I didn't expect by serving on these boards, building these relationships as well with my board colleagues and those staffs. Even attending events, right? Raise your own knowledge, your own awareness. There's great, oftentimes these groups will have forums or other platforms where you can learn more about the work that they do, and they do have deep expertise. And then really think about policies that can help. I mean, there is a moment now even to call legislators. The 501c3 status for many organizations is potentially a risk, right? And so even thinking through some of those policies and how we can be supportive, I would encourage people to do. So this is where we started. Some of these lessons that I carry with me that I continue to rely on and look back at, especially when I am at junctures and trying to think about what to do, this can be very helpful. So I'll close with the call to action, right? Which is a wrap of some of what I was just saying. It's an invitation to think maybe anew and differently about your time, your talent, your treasures, right? And what you can do to contribute to all of the communities that you're a member of. And I thank you in advance for doing that. And with that, I'll close.
Thank you very much, Marcella. Terrific talk, inspirational, informative. And to continue this work, I think whoever is involved in this kinds of work will require not only resilience, but also courage moving forward, and because there is a lot of onslaught on some of these ideas. So I cannot thank you enough. I really cannot thank you enough. I mean, this is a very fulfilling life that was displayed over the last 50 minutes in front of us. So once again, very inspirational. With that, any questions for Dr. Nunez-Smith? Anybody? Please go ahead, Jalis. Yeah.
So again, thank you very much for presenting this, and also for your call at the end, how we can be engaged in our communities. The question that I have is that that there might be changes in the upcoming years about how the federal government, our funding agencies value diversity, health disparities research, but at the core, maybe we may have to just rephrase our ideas without having to change them, because I think most of us who have been engaged in diversity and health disparities research have never been exclusive. We've always been tried to be inclusive, but maybe the inclusiveness has never been framed in a way that resonates with with certain parts of the US population that might now have to be reframed in that way. So I'm just asking you, how are you preparing for the changes that might be coming in the next years to still continue to engage in this work, to still be funded, to still make an impact on the community without letting this work get so politicized that it leads to gridlock?
Yeah. No, thank you. I appreciate that question. I know many folks are also pondering similarly. I think maybe just a few things to say. First, to your observation that really when we talk about who is affected by disparities, right, it's very hard, right, to not know someone, right, who is directly affected. The expansion of thinking about disparity populations at NIH, I think, is also critical, and I think that's part of the work that we need to do, right, is be able to remind everyone there are disparities, obviously, in aging, in geography. There are disparities by race, ethnicity. There are disparities by, as NIH says, like sexual and gender minority status. There are many groups that are affected, people with disabilities, right? And thinking about the work that is done really importantly for these groups. That leads me to my second, which is these are very important questions, but if and as we keep our eye on sort of the North Star here, like as I talk with policymakers, right, as you sit with elected officials, I would dare say the conversation doesn't really begin with like, is this about, equity or not? Like it's about someone who is their constituent, who is affected, right, by disparity. And one of the things I think that we as health equity researchers have maybe underutilized is been our power to connect with people around that narrative component of how disparities show up in the lives of so many people, right? And I think that is one of those opportunities for us now. You know, and I will maybe say, especially here at UIC and in this room and in Chicago, a lot of the work and advances, innovation, you know, I suspect we're going to see in the next, in the short to moderate term, it's going to be at the state level, right? And local, and equity is always hyperlocal anyway. But I think especially now, it's an opportunity for us to think about those state level innovations. I feel like in Chicago, Illinois, that's going to be one opportunity. I sort of went through at the end, but I think it's important, you know, specific to your funding question, there is no way philanthropy can stand fully in the gap. And we'll see. I mean, I'm not entirely sure how that will go with federal funding sources, but I think that there are opportunities there. You know, one of the groups that I didn't talk about all the groups that I'm part of, one of the nonprofits I'm on the board of received an unsolicited gift for $500,000, right? In the days following some of the concern about what would happen. So I think that there are going to be moments like that as well to step forward. But I haven't yet said that, you know, we're going to see a complete movement away from this. I teach at our School of Management too. I teach a class around, you know, the business case for health disparities. There are many different reasons to bring people to the table to think about health disparities, and certainly cost is also one. And we continue to be very cost sensitive. So, you know, it's the right question. I'm grateful to be here to think about this with all of you, but I do think that there are pathways for us moving forward.
Well, we're at the end of the hour. Why don't we thank Dr. Marcella Nunez-Smith once more. And then I invite all of you to join us in the Faculty Alumni Lounge for a lovely reception where you can continue the conversation. Thank you all very much. And once more.